Hi, I'm Janelle from PACOP and with me is Laura, and today we're going to present to you an interesting piece of research we've done, and it's called Introducing PROMs, Patient Reported Outcome Measures, into Aged Care for Resident-Centred Symptom Monitoring. Before we get started, we always like to start with an acknowledgement of country. So PACOP wishes to acknowledge Aboriginal and Torres Strait Islander peoples as the traditional custodians of the lands we're meeting on today. Well, we're not meeting, but we're presenting on. We want to pay our respects to elders past, present, emerging and future, and the lands that Laura and I are sitting on today are the Dharawal lands.
So today we're going to talk about getting SASsy with assessments in aged care. So we're going to talk to you about the introduction. So from thought to trial, how did we come about with the PCOT wicking trial? The method, how was it used in aged care? The results for the last 18 months of SASS collection, and then the conclusion. The SASS is great, but Janelle, what did we find?
Let's have a look.
So the introduction and background, moving from a thought to a trial. So the introduction to the SASS. The Symptom Assessment Scale is a patient-rated tool measuring distress in 7 common symptoms across palliative care. It's developed in the 1980s and it's since been used by specialty palliative care services in Australia as a PROM, so a patient-rated outcome measure. The PCOP SASS has been validated and used extensively for over 15 years by specialist palliative care services. In 2019 and 2020, the SASS was introduced into 8 aged care homes across Australia as part of a trial of regular standardised assessment of residents to identify palliative care needs and end-of-life needs. Here's what we found. And so really, it all started with PCOC, so the Palliative Care Outcomes Collaboration. PCOC is a well-established evidence-based national program used in over 90% of specialist palliative care services over the last 15 years. The successes of the PCOC model in community and inpatient settings led to the thoughts about whether we could adapt that model and use it in residential aged care. So we know that through the Royal Commission into Aged Care, there's been a real spotlight shone on palliative care and the aged care sector. And we know that over 60,000 Australians die in aged care each year, and 1 in 5 of those die within the first 3 months of admission. So we really need to put in some standardised assessment tools around identifying palliative care needs. So we already had this amazing model, and we wanted to see if it would fit and how we could use that. So PCOC is all about palliative care, and so through funding provided by the Wicking Trust, we conducted an aged care trial throughout homes in Australia from 2019 to 2021 with a modified PCOC tool.
This next section just outlines the methods of the trial of embedding PCOC into aged care.
So the method, PCOC wicking. So we embedded PCOC, routine assessment and response protocols, into residential aged care. And those with a prognosis of less than 12 months were screened in. So a 12-month surprise question.
Well, that must have screened in a lot of residents, Laura.
A lot.
Let's find out.
And so resident symptoms were monitored daily using the PCOC SASS by healthcare professionals, so registered nurses, ENs, care workers. And other assessments were conducted daily or weekly depending on the resident's phase. So the palliative care problem severity score was used, the AKPS and the RUG-ADL. And then lastly, the palliative care phase. This clinical information was captured with specifically designed software called PalCenter, and then de-identified data was encrypted and sent to us every 6 months for analysis.
So continuing on with the method, residents that were identified as needing palliative care reported their level of distress across those 7 symptoms included in the SASS, plus any other symptoms they were experiencing, and it was the distress from those symptoms over the previous 24 hours. The SASS scores were monitored daily by care staff or clinical staff, and staff were educated regarding the SASS. In particular, that resident-rated SASs were the gold standard, that the SASS is about the distress that symptoms are causing them rather than severity. And the distress is scored using a numerical rating scale where 0 is no distress at all and 10 is the worst possible distress they could be experiencing. SAS scores greater than or equal to 4 were classified as moderate to severe distress. And much of the results that we're presenting you today fit into that category. Any other symptoms were also recorded, they were scored, and they were also specified in writing. So we have a huge list of what those other symptoms were reported. The SAS scores were reported in the software that was provided, and de-identified information was sent to us, the PACOP wicking staff that were working on it for analysis at the time.
And so the PACOP symptom assessment scale, it's validated by PACOP through that 17-year use. It's resident rated and assesses the distress caused by the individual symptom. The 7 common palliative care symptoms are assessed and any other. And as you can see here on the example of the SAS ruler, those symptoms are listed. So pain, fatigue, breathing problems, difficulty sleeping, bowels, nausea, appetite, and then the other. And that facilitates early identification of change in the resident's needs.
So what did we find? Here are the results from 18 months of using the SAS. So here are the results from 18 months of getting SASsy with assessment in aged care. So this includes the results from recording the daily SAS from January 2021 through to June 2022. This involved collecting the symptom assessment scale from 323 residents, and look at that figure, 28,871 times a SAS assessment was gathered. And if you just pause for a minute and think about the difference that made. So 28,871 times a resident was asked about symptoms that were distressing to them, that they previously weren't formally asked about. So this is huge.
For resident-centred care, absolutely.
Yeah, huge.
And so here's a bit of the average population for our aged care trial period. And so we found that 62.8% are female in resident populations, and that collaborates with a lot of the data that we see coming out of the sector. And the average age was 86.6 years old, and the range was 60 to 106.
Wow.
83% had a non-malignant diagnosis, and of those, almost half, so 45.5%, had a form of dementia. And when we think about this demographic in that palliative care cohort for aged care, it's vastly different to the type of statistics that we're seeing coming out of community and inpatient sectors.
Yeah, and in that category of where we say form of dementia, it included the recording was either Alzheimer's or other dementia. So they're the categories that were included in that dementia section. So as I mentioned previously, because we had so many results, over 28,000, we decided we'd really focus on those with moderate and severe distress from a range of symptoms. So what we've done here is, of those results, is grouped the 7 symptoms, including other, into the proportions found reporting moderate or severe distress. So it wasn't unexpected that we saw pain as the highest proportion with moderate severe scores. You can see there just over 10% of people reported moderate severe distress from pain. But the second category was one that we found really interesting, and that was the other category. So there's going to be more on this later, but we thought that that was really interesting, that was the second highest category that reported moderate or severe distress. And there's a whole range of things that were reported there. Third on the list was fatigue, where 6.5% reported moderate or severe distress from symptoms. Followed closely by appetite and breathing. They were very close, around 4%. And then really down low, this was surprising to me. I thought bowels would be a lot higher. So obviously these are being well managed in aged care, and I think it is on a lot of us clinicians' focus and radar when we think about bowels. That was quite low, 1.4%. Nausea and sleeping were also quite low, less than 1% reported moderate or severe distress from those 2 symptoms.
And so the SAS, now the gold standard is that it's resident rated. So that's why it's a PROM. But where a resident cannot complete the SASs because of perhaps a cognitive impairment or a dementia diagnosis, we provided proxy options for scoring. And so proxy scoring was taught to score from the resident's perspective, and that could be done by the health professional or family. And so for the SASs assessments where the rater was identified, so 28,653 assessments, 94.3% were completed by the staff. And so that's healthcare professional or aged care staff.
That's really high, isn't it?
Yeah. And so this had us asking, what does this mean for the other symptoms when they're rated?
So we did some initial exploratory data analysis. Because of the high proportion that were staff rated, we wanted to just have a look to see if there were differences between the staff rated and resident rated scores for our two highest domains where there was moderate or severe distress. And they were, of course, just to remind you, pain and the other category. So, and I stress this is initial exploratory data analysis. It's in no way a statistical analysis, but it's just a raw look at the data. So there are some issues, of course, and you can see for SASs with pain, the number of resident rated SASs was 1,468 compared to 27,021. So initially you would start to go, well, there's huge differences in the number that are included in this. So that's why it's just a little glance, I guess. But I guess what stuck out for me, what appears to look like that staff were slightly more likely to report that there was no distress from pain. And again, I stress the numbers, make these, we should look at these results with caution, but it's interesting nonetheless. For the mild category, there was very little difference there, and only a small difference there for the severe category as well. But it does appear that residents, well, there's 4% more likely to report moderate or severe distress. But again, stressing that the numbers are quite different. So keeping what I just said in mind in relation to the pain category, the other category, as you might remember, was the second highest rated with proportion of moderate severe distress. So here's the breakdown of resident rated versus staff rated for other. Again, keeping in mind the numbers are quite different, but at a glance, you can see here that residents were more likely to report they had no distress at all from any other symptoms. What I find interesting down the bottom here is that staff it seems like the results there say 25% versus 52 that were twice as likely to not report any score or other symptom at all. And here in the moderate severe category, you can see at a glance though, that it seems that residents were more likely to report moderate or severe symptom distress from something other than the 7 symptoms that are recorded through the SASs.
And that reflects some of the validated research that we're finding where staff tend to underscore and families tend to overscore when we're talking about proxy scoring for people.
Yeah, there's been some initial research that PACOP has done in the validation of the SASs, and that has been some of their findings. Yeah. So as you probably gathered, we're pretty intrigued by this other category, as it was the second highest rated for moderate and severe. So about those other symptoms. So in the resident, keeping with the theme of dividing the resident rated versus staff, we thought we'd look at the top 3 broad themes that we identified. So in the resident rated, we used the data where they specified in writing what the other symptom was after they scored it. And so here are your top 3 categories. So out of 141 where they rated other symptoms as moderate and severe, 39 of those were related to mood, and that's where they reported anxiety or anxiousness or depression. The second category were 30, involved 30, and that's where they reported feeling agitated or restless. And the third category was itchy. So it was related to skin problems. And I just want to note here that when I mention behaviour, I just want to acknowledge that, we believe behaviour is a manifestation of a symptom, something going on. It's not a problem in and of itself. It's usually a manifestation of something going on for the resident. And so we thought that was interesting, and that's the resident rated section for the top 3. Let's look at what happens when you talk about staff rated other symptoms. So continuing with the theme of looking at the other symptoms, here's what the staff rated. So you can see with the top 2 categories, behaviour and mood, from the resident rated, they've been flipped, where behaviour is the most frequently reported. So from 3,428 records, 301 of those involved something or words that we've arbitrarily grouped under the heading of behaviour. And so some of those words they used were aggression, agitation, or the word behaviour, confusion, hallucination, delusions. They were grouped under behaviours. The second category, where there were 195 reports, included words like depression, anxiety, crying, emotional, sad, and even loneliness. And the third category, third highest reported category, where there were 89 records, was care related, and so they were words like care provision or providing care and hygiene. So you can see it's interesting they have the same sort of top 2 categories. A lot more work needs to be done in this area, but we found this interesting to just start with our initial exploration.
Conclusions. The SASs is great, but where to from here?
Yeah, indeed, the SASs is a fantastic and innovative addition to aged care, where we're really asking residents the things that are distressing and bothering them. But there's some things we learned from this research.
The SASs. So PACOP is introducing a PROM into aged care, which is innovative. And the SASs allows residents and staff to advocate for distressing symptoms and for staff to facilitate resident-centred care.
So important, and as we've seen here, really drilling down to those 7 common symptoms, but also asking them what else, is there anything else that's distressing to you, is really allowing homes to care plan that's just so based on what's important to the resident.
And focus on what's going to improve their quality of life and their experience. And the journey for each individual resident is really what we're trying to improve.
Yeah.
And so the aged care setting is very different to a specialist palliative care setting, and we know that the aged care environment is very different to a hospital and community palliative care environments as well. And so we've seen that in some of this exploratory look into the data. And so we know that good education has to accompany the use of the SASs, because we do have a high level of people who are proxy scoring. And so to encourage them to make sure that it's resident focused and rated on their distress and their things that are important to them. And for proxy scorers, if that's going to remain high, then we need to investigate why that is and make sure that we're really doing it well.
Yeah.
And so further research is required to identify potential common themes for our other symptoms. And perhaps we may need to modify the SASs for use in aged care to ensure that it's meaningful for that resident population, because we saw that there were those 3 main categories that had under 2% have reported for moderate to severe symptoms. And so perhaps we can further adapt and learn and lead to improve symptom management and quality of life for residents in aged care.
It's an exciting space to be starting to work in and to watch it grow as we gather more data on the SASs, that's for sure.
And so, getting SASsy with symptom assessment in aged care. Let's have a look at the key take-home messages and what we need to focus on to make sure that we're SASsy in all the right ways.
So we're so grateful to actually have the PCOP SAS tool to be using in our collection at PACOP. It's an innovative thing in aged care, introducing a PROM, and it's exciting that we have this really well validated tool to use. And we've talked about today that, you know, it's been used for years, almost 17 years in specialist palliative care services, to really get to the bottom of what's bothering patients. And we are really excited to be introducing it into aged care to really drill down on what's really bothering or distressing to residents as well. So as you heard at the start of this presentation, we trialled it in residential aged care. And as a result, through those extensive trials and feedback from the aged care homes, we've adopted it as one of our core tools for really focusing on resident-centred care. But this just brief, you know, exploratory data analysis, not even extensive research, has highlighted that there's some interesting differences between what we see in the palliative care space and what we're seeing in the aged care space. And it's largely related to the different demographics, but also the different setting. So we're asking ourselves, you know, as we gather more data, does more work need to be done to make it really meaningful, to make sure that the staff and the residents are reporting on symptoms that are meaningful to them in aged care? So it's an interesting space to be working in.
It is. And in the meantime, absolutely, staff need to ensure that it's proxy scored from the resident's perspective and really guiding that resident-centred care for them, because it is a PROM.
Yeah, and our key message moving forward in PACOP as well is to try and bring those resident-rated scores up through a really a good quality education package to help staff really get the residents to either tell them their scores or either self-report. So that'll be a work in progress for us at PACOP.
And so what started with PEACOC and the PEACOP Wicking trial has formally finalised and ended with PACOP. Thank you so much for watching some of our insights from our PEACOP Wicking trial period. And if they want any more information, Janelle, they can always check out our website or send us an email. And we are fully funded by the Australian Government Department of Health and Aged Care.
Yeah, thanks so much for joining us. Please do write down that email there and send us any questions that you might have about our ongoing work with the SASs and really getting to the bottom of what's bothering residents in aged care. Thanks for your time. Bye.